Good day, everyone. I'm so privileged to be your moderator for this session on expanding our understanding of palliative care. We are joined today, by very esteemed speakers. We have Dr. Suresh Kumar and Dr. Dia Martina, and our reactor will be Dr. May Corvera of Ruth Foundation for Palliative Care. So, to start, let us understand what palliative care is. I'd like to introduce Dr. Suresh Kumar. He is the director of the WHO Collaborating Center in Community Participation in Palliative Care and Long-Term Care. He is the founder, director of the Institute of Palliative Medicine, and his areas of interest are developing palliative care in low and middle income countries, community participation in palliative care, and he has been active in palliative care scene in India and abroad for the last 27 years. So friends, let us all welcome Dr. Suresh Kumar. Dr. Suresh, over to you.
Thank you, Fatima. Good afternoon, everybody. I'll briefly talk about palliative care. I have a few slides. Let me see. Let me share. Yeah. Is visible? The screen is visible. You can see the screen? Yeah. Okay. This is about understanding palliative care, particularly in the context of breast cancer and palliative care in general. So when you look at the basic question, what is palliative care? I'll come to the definition later in another slide. But this is basically an exploration as to what can be done to avoid suffering, to reduce suffering in the last phase of our lives. That which is the last phase cannot be defined in terms of so many hours or so many days or so many weeks, but generally when the disease becomes incurable and there is no going back to normal routine, this is where palliative care comes in. And the standard definition by WHO talks about improving quality of life in the case of life-threatening illness, and also prevention and relief of suffering. And also, so the target group is not just patients, but patients and immediate family members. So the keywords here are one, prevention and relief of suffering, not just a symptom or not just a one diagnosis, but suffering is a broader term. And then in the case of life-threatening illness, and also the target group, because invariably it's not just the patient that is affected, it's the patient and family. So who needs palliative care? When you look at this question, let's look at a few facts of life. One is that we all have to die one day. Anybody born is expected to die one day. And also another important fact is that only 10 to 15% of us will die suddenly, unexpectedly. 10 to 15% of us, death happens totally unexpectedly, suddenly. But with the rest of us, the majority of us, the up to 85 to 90% of us, we will be dependent on others, functionally impaired and in serious illness for the period before we die. We may be bedridden, we may depend on others for our daily activities, we may depend on others for our survival. So that's how 85 to 90% of us are likely to spend our last days. And palliative care is for these 85 to 90% of us who, irrespective of whether you have a major disease, irrespective of whether you are dying or at an old age, irrespective of whether we are you are man or woman, or whether what age you are, 85 to 90% of us will need support, and palliative care looks at how this support can be optimized, how this support can be improved. And when you look at this, who is actually, who will look after you when you have a serious illness? Who will look after you when you are bedridden? Who will look after you when you have only a few days or months left in life? You are dependent on others. When you look at this, you can see that I'll use my laser pointer here. Yeah. You can see that we have three systems around us. The patient has three different systems to look after. One is what we call the formal health or social welfare system. This may be your primary health center, your hospital, your home care teams, anything related to healthcare. And then the patient also has what we call an informal personal support system, mainly family members or the immediate carers who spend time with the patient, who are with the patient almost all the time. And then in many places, there will be some sort of a community support system, distant relatives, neighbors, friends, and some of the non-governmental organizations, religious groups who may drop in and support. So any patient is basically looked after by the three systems. In some places, one of the systems may be really good and the other two may not be as good as possible. In some of the other places, two systems may be good. But essentially, elements of all the three systems are there. The informal personal support system, immediate relatives and other carers. Then the community support system, distant relatives, friends, neighbors, and groups, NGOs, and religious groups. And then definitely the formal healthcare system. So when you look at care, when you look at who is looking after, when you talk about improving care, you need to consider all the three systems. And then there is something called the what we call the 95% rule. And this is from the data shows that patients in the last phase of their life, patients in palliative care, they spend 95% of the time outside institutions care. They don't spend a time, or they spend only little time in hospitals. Most of the care is delivered not in hospital or not by doctors and nurses, but by family members, friends, and neighbors. These are the people who are around the patient most of the time. The patient may get admitted in between, or patient may attend an OP service in between, a home care time may visit in between, but most of the time, 90% of the time, is the family members who are with the patient, is the relatives, other friends who are with the patient, or the neighbors who are with the patient. This also we need to take into consideration when we talk about improving the quality of care. And the ideal system of delivery, this is something that is advised by WHO, and this is what we call the public health approach to palliative care. You need specialist palliative care services only for a few. A few people with complicated problems, difficult problems, will need a specialist, will need a specialist center, and this is only for a few. Most of the problems, most of the issues can be sorted out at the primary healthcare level. So palliative care by the primary healthcare team. And again, it's very important that the two other systems that we mentioned, informal care system, the immediate family members and friends and neighbors and civil society groups also play a major role. And when you look at specifically about the patient with advanced breast cancer, we can categorize the problems into four broad categories. They overlap because each of the physical problem may have an emotional component. The emotional problem can worsen the physical problem. But when you make a list, physically you will find pain, breathlessness, fungating ulcers, vomiting, etc. Emotionally, you find panic, sadness, anger, worries, anxieties, feeling helpless, altered body image, etc. Social problems may be financial or maybe strain in relationships due to the disease and due to the different functional status. And very often people feel socially isolated also. Then there are spiritual problems related to suffering, related to the meaning of life. If they are religious, there may be religious concerns also. So these are the four major categories of problems that we face. And then when we talk about relieving suffering, we need to look at the whole thing holistically. we need to look at all these problems and we need to address all these problems so that we can reduce the suffering. The physical domain, mainly pain, nausea, vomiting, punctating wound, bed sore, confusion, breathlessness. But the key point is the doctor, the nurse, the medical team should be able to control the symptom. The patient has a right to be free of symptom, irrespective of whether the disease is curable or not. Even during the phase of curability or later, if the disease is incurable, that's immaterial. The patient has a physical problem, patient has a pain, patient has a nausea, or patient has is developing bed sores or has confusion or breathlessness. There's a right. It's a right. Patient has a right to be free of the symptom, and it's the responsibility of the healthcare professional to see that the patient is free of the symptom. That is a physical domain. And the psychological domain, patient and family members will need emotional support, and the healthcare professional should know how should have the basic communication skill to talk to the patient and family in a supportive way. Also, we need to make sure that people who are around the patient also know how to talk to the patient and family members. That social domain, social isolation is there, and also a lot of problems caused by because the society may not support the affected member as much as he or she need. And so the question is again the question, the challenge there is how can we ensure that the necessary social support in a society which is not ideally, there are also gaps there. How do you avoid social isolation? How do you make sure that the patient has companionship? How do you make sure that the financial problems are handled? So these are some of the issues. And then the spiritual domain, spiritual issues. How do you find meaning? Like when you have only even limited time, life expectancy, you have only limited time to live. How do you make sure that you find some meaning there, meaning and purpose during the difficult phase of life? This is also an issue. So when you talk about palliative care, when you talk about supportive care, when you talk about what is the care that the patient needs, all these need to be taken into consideration. So how do you ensure this? How do you ensure that somebody with serious illness is looked after well? How do you ensure that their problems are addressed? One, you need a system to inform and guide the patient and family. It need to be available and also accessible to the patient and carers. If they need to some guidance, so we need some support and information. There should be a system available, readily available, accessible. Then there should be a system to support the physical, psychosocial, and spiritual needs. These need to be addressed. And also the three systems that we mentioned, all the three systems are there. The informal personal support system, the community support system, and the formal care system. But we need to make sure that they are competent enough. They can handle the situation, they can address the issue, and also that they can work in a coordinated way. This is not happening in most places. So when you look forward, what is the way forward? Way forward is to build capacity. The primary healthcare system and the hospital system should have the capacity to address the physical symptoms, the emotional problems, and also take a lead in the care. So they will need training, the doctors and nurses who are at the primary healthcare level or at the hospital level, irrespective of what specialty they are of. They will need training and skill building in handling this patient. And also the patient should have improved access to these facilities. So that is the primary health, the healthcare system. And then the personal informal care system, which is basically the immediate family members, the immediate carers. They also have a lot of problems. They are also confused. They need fairly good psychosocial support for the carers also, and information and training so that they can look after the patient really well. They need to be supported. And then the informal care system in the community. There are a lot of people who are willing to support a patient in the neighborhood. There are a lot of people who are willing to support the carers with the patient. So these people need to be oriented, sensitized, and connected with the patient and family. And also there should be a network. They should be allowed to network with each other, with other groups, and also with the family carers and other people. So we need to make sure that all the three systems have the capacity to do this. All the three systems have the skills to do this. All the three systems work with each other, and all the three systems support each other. Thank you very much. This is basically what it is all about. This is basically about what you need and how you need to develop, and particularly when somebody, and also this sort of, if you have a facility like this will be useful in all the phases of the disease. The patient may need a lot of emotional support and social support from the very beginning of the disease process, when the point of diagnosis, during the curative therapy phase, during the rehabilitative phase, during the palliative care, terminal. So we need to strengthen all the three systems to make sure that this happens. Thank you very much, and then I'll be happy to take some questions after my second presentation. So thank you very much.
Thank you so much, Dr. Suresh. My two takeaways from your talk is that palliative care is holistic care, and that everyone has a role in palliative care, especially family and community. So I'd like to introduce our next speaker, who is Dr. Dia Martina. She is a faculty staff of the Division of Psychosomatic and Palliative Medicine, Department of Internal Medicine, Faculty of Medicine Universitas Indonesia, and a medical staff in the academic top referral National General Hospital, Cipto Mangunkusumo Hospital in Indonesia. Dr. Dia takes part in many international research collaborations with Asian countries, Europe, USA, and Africa. She has published several publications, including a Declaration of Advanced Care Planning in Asia. Friends, please welcome Dr. Dia. Dr. Dia, over to you.
Thank you. Share my presentation. Thank you very much, Mrs. Fatima. Can you hear me? Some of you may be familiar with this picture. Some others may not. This is a movie in 2019, directed by Lulu Wang, based on her true story of her grandma, Nai Nai, who lived in China and was diagnosed with terminal cancer. She was given 3 months to live. Instead of telling her grandma about her terminal condition, her family decided to keep it secret and fake a wedding party in order to enable family members from 3 different countries come to China to say goodbye, without letting Nai Nai know they were actually saying goodbye. It's a giant farewell party disguised as a giant wedding banquet, the lie that everybody agreed upon. In this movie, little Nai Nai, or Nai Nai, younger sister, told Wang about this Chinese joke. 2 people go get a physical examination. One of them is healthy, and the other one has a terminal illness. The hospital got the result mixed up. The healthy person got to know he had terminal prognosis, and vice versa. Eventually, the healthy person ends up dying, while the sick person ends up living.
Dr. Dia.
It's not really funny for a joke.
Excuse me, Dr. Dia, excuse me. I think your lapel mic is bothering or disturbing our audio. Are you using a lapel mic? Or yes, maybe if you could put your mic closer to your, as you speak. Yes, because we're hearing some scratching sounds when you speak. So there, maybe you can start with this slide. Thank you, Dr. Dia.
Okay. Is it better without, maybe? Is it better now?
Yes, it's very much better now, yes. There, it came back. You're flipping,
you hear me now?
Are you flipping pages, Dr. Dia?
I cannot hear you.
Are you flipping pages? Maybe if you don't use your...
Yeah. Is it now okay?
Yes, now it's okay. Maybe just move it closer to your...
My mic, yes. Yeah.
Okay.
Okay. Yes. So
Thank
it's
you.
not really funny. Yes. Thank you. This joke was not really funny for a joke, I know. But the message was the belief that it is not only illness that kills, it's also the fear. We should give Nai joy, not worry. This was the scene that explained the most important values underlying the situation, where her uncle told her, Billy, or Wang in the movie, you moved to the West a long time ago. You think one's life belongs to oneself. But that's the difference between the East and the West. In the East, a person's life is a part of a whole, family, society. It's our duty to carry this emotional burden for her. Nai's story is intriguing and disturbing even for many Western people. But for us in Asia, Nai is our neighbor. Nai is our friend. And maybe someday, Nai is us. Today, I will be sharing my studies about the Asian perspectives on advanced care planning. Before we talk about ACP in Asia, let's talk about what ACP is. Advanced care planning enables individuals to, first, define goals and preferences for their future medical treatment and care. Second, to discuss these goals and preferences with family and healthcare providers. Third, to record and review these preferences when appropriate. Fourth, and to review. So, originally, advanced care planning was aimed to have patients make treatment decisions in advance so that the clinician can attempt to provide care consistent with their goals. Advanced directives are the methods most often used to achieve these objectives. However, over 30 years of research showed that ACP had failed to affect quality of care at the end of life. It had failed to improve clinicians' and surrogates' knowledge of patients' preferences. Therefore, focusing on the documentation or the completion of AD can actually be counterproductive to the actual aim of ACP. In the last 2 years, it has been debated among international ACP experts whether we should continue research and investment in ACP. What are the problems with this traditional objective or focus of ACP? Number one, prediction. It is difficult to predict what we want in the future hypothetical scenario. Number two, adaptation. Patients' preferences changes with health at the end of life, even during periods of stable health. Number three, extrapolation. It is difficult to determine as a healthcare professional when is the condition is irreversible or terminal. Number four, the nature of surrogate decision-making. It is easier to make decisions about intensive therapies, but when it comes to less aggressive therapies, it is more difficult for them. For example, giving blood or antibiotic. Therefore, a shift to the main objective of ACP had been considered to be shift from making premature treatment decisions based on incomplete or hypothetical information into preparing patients and surrogates for the types of decision and conflicts they may encounter when they do have to make in-the-moment decisions. By supporting patients in understanding their condition and reflect on it and explore their values and goals. ACP can be initiated since the diagnosis of serious illness and be repeated or reviewed across the continuum of the illness, including transitions of disease phase. Nowadays, ACP has even been promoted to those without serious illness, particularly after the COVID pandemic, where an infection can cause deterioration among those who are not necessarily having life-limiting illness. The focus of this discussion, however, may vary between healthy population and those in the end of life. There are many tools to guide ACP conversation in clinical practice. This is one of them by Ariadne Labs. Number first, introduce the idea and benefits and ask permission. Is it okay? Number two, assess their understanding about their illness and their information preferences. Number 3, share the prognosis. Do not forget to tailor information based on their preferences. Allow silence and explore emotion. Number 4, explore key topics. Number 1, first topic, goals, fears and worries, sources of strength, critical abilities, what are the trade-offs, and family. And then close the conversation, make a summary, and document your conversation. However, most of these guides were developed in Western countries based on Western culture. The current international consensus on ACP had been developed by a panel of experts from 8 Western countries, including Europeans, North Americans, and Australians. Following its publication, a panel of experts in Asia issued a declaration proposing the need of cultural adaptation and the importance of research focusing on strategies for conversations and culturally sensitive model of ACP in Asia. Why do we think a cultural adaptation for ACP is important? ACP is rooted on mainstream Western bioethics of patient autonomy, truth-telling, and control over dying. All of these leads to self-determination, the philosophy of ACP. However, in Asian context, self-determination is not always valued. There is collectivism, where social harmony is more valued than individual autonomy. There is medical paternalism and social hierarchy, where people might differ their decision-making capacity. Role. There are preferences for implicit communication, and there are low level of autonomy among the elderly. The next presentations will be informed by the following studies. Let's start with the conceptual framework that we developed based on mixed method systematic review. We learned that willingness to engage in ACP was affected by patients' knowledge of their disease and ACP. Their various beliefs, whether ACP is advantageous or disadvantageous. That ACP should be in accordance with patients' faith or religious beliefs and their families or physicians' wishes, and their beliefs about the presence of barriers to it. All of these factors will decide whether or not they would engage in ACP, which role do they take, when, and whether they want it to be documented or not. For the sake of time, this presentation will not cover the study findings, but will focus only on the implication of the study findings and summary of recommendations regarding ACP in Asia. These are 4 main recommendations for ACP in Asia. Number 1, partner with family. Family is important anywhere in the world, regardless of the culture. However, evidence in Asia showed consistently that significantly more Asian patients are willing to engage in ACP with their family members, with or without the presence of their healthcare professionals. These findings suggest that ACP, even more in collectivist cultures such as Asia, is a relational process. It is enacted less as an individual directive and more as a family-centered and social process. Therefore, providing support to family will further provide support to the patient's engagement in ACP. Family members can serve as a bridge to communicate patients' values. Family members can be patient healthcare proxy, therefore eliciting not only patients, but also their family members' views and addressing their concerns and emotion, facilitate open communication of it with patients is important. However, what often happens is family requesting the clinician to conceal bad news. To answer this problem, I want to draw your attention to this framework that recently was developed and published in BMG. This is the first framework that actually addressed the dilemmas of facing family who ask for non-disclosure of information to the patient. First, you need to acknowledge the request. Say that we understand about your concern. We want to talk with you and understand your perspectives. Number 2, build the relationship. When you ask us to not tell the diagnosis, what's on your mind? Are there particular things that you're worried about? What is the person as a person? What is the patient as a person? What things do you feel are most important to her? Number 3, find the common ground. And this is the most important thing. we can say we appreciate from what you say that your priorities are for her to be as comfortable as possible and not to be put under mental distress. These are goals that we share with you. Number 4, honor the patient's preference and outline harm of non-disclosure of information. Continue with providing emotional support and response to their concern and devise a supportive solution. In this process, it is needed that we show some sensitivity to the grieving family, maintain cooperative relationships, and uphold, as far as possible, patients' right to information. Disclosing diagnosis and prognosis can be staged, offering varying levels of disclosure. Number 2, implicit communication. Our findings show that fewer Asians wish to know about their estimated life expectancy, for example. Patients and family appreciate sensitive communication, and that is by using implicit communication metaphors or euphemism. Healthcare professionals also find comfort in initiating difficult topics with the use of implicit communication. This is a quick reminder that different culture may request different level of explicitness or directness. Those living in high context culture agree that good communication can both be spoken and read between the lines. In our study, sometimes even the word malignant can be too harsh for the patients or family members. So it is better for them sometimes to use the word serious, or change the word delve into end of journey, because sometimes metaphor can also helpful. One of the example is insurance metaphor. I think about advanced care planning like I do car insurance. I do not plan on having an accident, but if I do, I will be glad I have car insurance. We have peace of mind driving down the road. This is an indirect approach to normalize ACP conversation that shows that initiation by non-family members, for example, community stakeholders and healthcare professionals, can be actually helpful. Making ACPs part of general routines in the medical checkup, for example, can also be helpful in the uptake of ACP so that the patients can feel less personally targeted. Contextualization. The concept of ACP can be alien or unfamiliar to our patients. Therefore, we need to contextualize it. For example, in Chinese culture, by using ancient emperors as a comparison. By saying, for example, in ancient China, only the emperors got to select their grave sites, rearrange their funerals, and to make wills. The ordinary people or peasant could not do it. So I asked my members, do you want to be an emperor or a peasant? With a joke, of course. The concept of utility is another example that it can be irrelevant for those who believe that life is sacred loan that should be protected. And often these people avoid conversation about limiting aggressive interventions. The use of appropriate religious terms to navigate the conversation, contextualize the message, and help clarify misconceptions has been helpful in making the unfamiliar familiar. For instance, the use of the term mudarat, which means harm and is forbidden in an Islamic context, was reported to help Muslim patients better understand the concept of futile intervention and distinguish it from giving up. What is the evidence related to religiosity and ACP internationally? Is religiosity a burden or is it an opportunity? There is a common assertion that religiosity accounts for lower rates for ACP. However, the emerging evidence showed that actually religiosity and spirituality have potential for opportunity. Lastly, our study showed that patients often express that the concept of future planning can be very complex for them, especially when they believe that life is God's sole authority. And rather than planning it, accepting whatever God has planned for them is considered what they should do. When they believe that preserving one's life is an obligation, so they preferred in prioritizing doing their utmost effort on it rather than thinking about when things got worse. when they believe that worst case scenario is not happening to them because they were still in early stage or because they don't really understand what advanced cancer means. When people were unready and avoid discussing topic that makes them feel sad. And lastly, people find it easier to discuss what matters most to them. The complexities of future planning showed the importance of shifting the focus of the conversations from exploration of goals into exploration of values, creating connection, understanding what matters most to a person. A study by Zwakman told us that every patient is ready to engage in certain elements of ACP. They categorize the elements of ACP as easy topic, somewhat difficult, and predominantly difficult. The study also discovers shift in readiness, showing that patients' readiness can shift. It starts with being aware. Although patients show that they are unready with certain topic, by introducing it, we promote awareness and hope for the next step. After recognition, acknowledgement, and eventually acceptance, and being ready to engage in discussing it. Sorry. So what we need for ACP in Asia is an approach that upholds social harmony, appreciation that information provision and advanced care planning should be individualized based on patients' unique needs and belief system, and that ACP should focus on promoting meaningful conversation and facilitate mutual understanding between patients and families and healthcare professionals, rather than merely focusing on making treatment plans in advance. ACP should focus on creating connection between patients and their family members, patients and their healthcare professionals, and most importantly, between patients and themselves. Most of us has our own reason to choose our path. Why in the beginning we decided to care for the sick. Most of us started this journey because of love. Love to our beloved families, love to the ones matters the most to us. We want them to be seen and treated as a person that means everything to their loved ones, as a mother, a grandmother, a love of one's life. But somehow, during our long journey, there are more to come. We want to defeat the illness, add years to life, reduce cost, and all of these things. And at one point of the time, we lose our focus until it becomes a battle between us and the illness. ACP should be the path that reminds us why we started what we do. ACP should remind us it's not the illness, it's the person that matters the most. Thank you very much. I want to also publicize Congress on Advanced Care Planning next year, May, in Singapore.
Thank you, Dr. Dia. It really takes relationship to implement advanced care planning and very good communication skills. That's my takeaway from your talk. So to react to our two speakers, I'd like to call on Dr. May Corvera, who is the Family Medicine and Palliative Medicine Specialist with the Asian Hospital and Medical Center and the Vice Chairman of the Department of Occupational and Family Medicine. Hi, Doc May.
Hello.
May we hear your reaction to our two speakers?
Yes, hello, and it's a good evening already. Thank you so much, Ma'am Gurley, and Dr. Suresh and Dr. Daya. Thank you for all that you've shared. And I guess I know our time is limited because we're running a bit late, so I was going to ask how long I actually have to react, but I'll just try my best to keep it short. In relation to how Dr. Suresh defined and shared with us all about palliative care and its importance, I think what we can share early in the session with all those who are listening is both the good news and also a challenge in our present national situation. So we know that the National Integrated Cancer Control Act with the IRR finished last 2019 included very well palliative care and pain management for all our cancer patients. And that is the law that was passed, and we are now gradually seeing that law rolled out as the national program for palliative and hospice care is also being worked on now by DOH. So just to backtrack on that legislation that was passed in relation to palliative care, it was really emphasized that the government in the declaration of that policy should really endeavor to improve cancer survivorship by responsive palliative care. And that's what Dr. Suresh was talking about, the holistic care of all our cancer patients by providing quality of life care and even survivorship care, starting not just with the actual relief of suffering, but with the prevention of it. And that very reason why palliative care can already partner with the care for cancer patients upon diagnosis, because we know that suffering begins upon the hearing of the word cancer. Whether you're stage 1 or stage 3, once you hear that word, there's already emotional suffering, social suffering, even spiritual suffering, asking why. So that is why we want to emphasize that the palliative care approach should be learned, should be embraced by all care providers, from physicians to nurses to even allied healthcare providers that surround that patient through supportive care, and going further to empowering the community to provide compassionate care. And that is why we're also looking towards the building of compassionate communities. The foundation I also work with, along with the Philippine Society of Hospice and Palliative Medicine, we will continue working with the Department of Health to make this accessible to all. And as we work with our regional cancer centers in that law, actually in that IRR that we worked on, the regional cancer centers are mandated to provide palliative care and even promote it and even undertake training for it and train their immediate community. So we're really hoping that we see greater access in the years to come, especially now that we're also working on PhilHealth coverage. That's another important point I wanted to share, although it's still in the works. But palliative care and pain management, survivorship and care, and even hospice care, hopefully we will see PhilHealth coverage for that. Home-based care, even provision of community-based hospice facilities or palliative care facilities. So we're hoping that soon the guidelines for that will be established and all Filipinos through the PhilHealth coverage will be given access to that, and it will be covered by our government. And we also want to share that even palliative care medicines, pain management medicines, are part of the essential medicines under NICA, under our Cancer Control Act. So again, all of this to show that a government has stepped up and we are working alongside them, and hopefully we'll see a good wave of this rollout soon. Now, I want to appreciate also Dr. Daya for sharing that very relevant and very important topic of ACPs and how it's progressing to contextualize it in the Asian culture, because truly it's been a uphill climb in our Southeast Asian area because of our culture. It's hard to introduce, but all of the valuable research that you have shared shows us how we should really put emphasis on values and culture in introducing it. And COVID has really taught us a lot. When I volunteered with a group of doctors who made algorithms during the COVID time, there was actually an algorithm we formed for advanced care planning. And now with this new information from the research, I believe we can improve that algorithm to emphasize the conversations more about values and making sure that family is very involved in the decision-making process. And we also look forward to that symposium where we're also working with the different groups to make it an ethical practice, advanced care planning, but again, to make sure it's contextualized. So I love how you said that it brings us back to our basics, how ACPs remind us how important it is to care for the person and the family that surrounds them. And I also recall a quote that I have an advance directive, not because I have an illness, but because I have a family. And maybe that can also remind us the importance of that. And I think there's so much we can still share about palliative care, but I want to thank the organizers for including this session so that we can continue advocating for palliative care as a primary care health service that all Filipinos are entitled to. And like we heard, 100% of the population is in need of palliative care at some point. And that's why it's part of primary care. So not only is it part of the NICA, palliative care is also part of our universal health care law. And that's why we should advocate it together. And again, just to emphasize, building communities, building compassionate communities, because doctors, nurses, the healthcare force will not be enough to implement palliative care. We need to empower our immediate communities, the neighbors of these patients, the churches, the schools, homeowners groups. They need to understand the palliative care approach because we need to deliver it as a community, side by side, and not just deliver it, but advocate for it, because it is truly a right of every patient to have this type of care and to make it included in standard care. So again, thank you for this time and opportunity to share with you.
Thank you, Doc May. So we invite our participants to give their questions, and maybe we could call once again Dr. Suresh and Dr. Dia to open your videos so that we can have a conversation about the topics that you talked about. I have a question for Dr. Suresh. Okay, do we see Dr. Suresh? Yeah, Dr. Suresh, if you can hear me, I have a question. From a patient's point of view, you know, it's difficult for us to learn about palliative care because, admittedly, it's still doctor-centric. So why don't our doctors talk about palliative care to us patients?
It's one major problem, like palliative care is evolving, but one major problem is in many places, people tend to see it as doctor-centric. It's not doctor-centric because doctors, a doctor has a role to play, definitely, but everybody has a role to play. So this is about you need not wait for the doctor to talk to you about support. You don't wait for the doctor to talk to you about emotional support, social support, spiritual support. And doctors are not I'm basically, I myself, I'm a palliative care physician. But doctors are not the people who can deliver this. Which doctor can deliver a spiritual support? Which doctor can deliver social support? So, it's for the patient and it's for the family, it's for the carers to talk about it. Like we don't even have to use the word palliative. What are the needs of the patient? The patient at any stage would need emotional support, social support, spiritual support, and also the physical symptom support. And who is going to provide it? So this is a question that we need to ask from the patient's point of view, the right-based approach. And then it's not something, an add-on that a doctor can provide. It's something that the patient need to demand, the family need to demand. We need such and such things, and it's for the community to respond. And like there was a mention about compassionate communities. That is how the compassionate community evolves. So we need to take it out. We need to define the doctor's role exactly, and we need to define the role of other people also. Yeah. That's what I feel.
Empowered, right, Dr. Suresh? The patients need to ask for supportive care. Let us be empowered. So once we are diagnosed with anything, whether it be breast cancer, we have to ask our doctors, aside from physical care, we also want supportive care. Dr. Dia, during the COVID times, this is when advanced care planning is really needed. Why is it that some are still not open to it, right? Because of the culture. You talked about it, about the culture, and you had points about it. Again, from a patient's point of view, as patients, how can we advocate for advanced care planning among our patients?
Thank you very much, Mrs. Fatima. I think this is a really, really important question. From our studies, we understand that approaching advanced care planning as a discussion about your end of life may not be easy for anyone. Therefore, we propose that advanced care planning should be approached as a conversations about knowing who you are as a person, what makes you you, what makes life important for you. So from this, we can eventually build connection, be it between patients and their family and with other people. So how do we do this in the community setting? There are lots of studies that mention that actually community stakeholders and community leaders had a big role, especially in Asia, because they are respected, and it feels safer for the patients or people who have chronic illness. So to have this game, for example, heart-to-heart games, or there are many actually games that is built for ACP. So we try to explore the values, and eventually we'll talk about goals, what makes life meaningful to you, what makes life not meaningful to you, how do you think life should be for you, something like that. So this can actually help us translate that when they come to end of life or serious illness. So approaching this kind of conversation casually can be very helpful. And eventually, I believe if we already have enough connection and trust, we can eventually approach the conversation about end of life. What do specific treatments do you want in the end of life, or what makes you think that some interventions may not be acceptable for you for your quality of life, something like that. So I hope that that answers Mrs. Fatima.
Yes, thank you, Dr. Dia. I would like to ask Dr. May. So Dr. Dia talked about capacity building, training. So in our setting, Doc May, are there plans for hospice or palliative leaders in our country to train patients regarding palliative care and advanced care planning?
Yes, so the Department of Health has already launched the national program, which includes basic training for palliative and hospice care and the intermediate level of training. The basic level of training can be for all advocates, not just for healthcare professionals. And this would be the venue where advanced care planning can also be taught as one of the topics. Now, going though more into the grassroots, I believe we can work with communities like Dr. Dia was saying, because given this is important for all families, especially during the pandemic, we saw the need to really share it with other groups, even churches. They were asking for talks about advanced care planning, senior citizens groups, of course, cancer support groups, but bringing this out and making a very intentional campaign, but in the context of culture. So I love the idea of how Dr. Dia emphasized that it's important to work through the community and present it in a way that is light and have it as games, but just to create that awareness by recognizing first what is important. So I believe it'll be part of the campaign of the Society of Hospice Philippines along with UH to empower the community and patients especially. So we will look at our, of course, regional hospitals, but we'll also look at cancer support groups around throughout the country and senior citizens groups through the OSCA. Different groups of chronic illness support groups. And this is one way we should connect with different medical societies as well and encourage them to offer these type of lay forums to their patients and families. So yes, it's on the roll, and we're looking forward to the coming year to roll this out alongside our partners and all stakeholders.
Thank you, Dr. May. We could ask Dr. Dia and Dr. Suresh as consultants, correct? We can take them, we can make them our consultants.
Yes, we'll invite you.
Yes. So
This is Fatima.
Yeah. Yes. So
If I may add on that last comment from Dr. Mai about the role of cancer support group. Actually, our study, nationwide study in Indonesia among cancer support groups, it was a survey, an online survey to more than 1,000 cancer survivors of all type of cancer. We received really positive acceptance to advanced care planning. More than 75% actually are supporting advanced care planning, and most of them are breast cancer survivors. So we think that eventually in the future, they are the community leaders that can facilitate engagement of advanced care planning in the community. Yeah.
Thank you so much, Dr. Dia. So I think our time is up, and we'd like to encourage everybody to promote, advocate for palliative care and advanced care planning, because it is our right for quality health care. So thank you so much, Dr. Suresh, Dr. Dia, and Doc May. It was really a pleasure having you.
Thank you.
Thank you very much.
Thank you so much.
It's an honor.
Maraming salamat po. So thank you for attending this session, and this ends our day, and we hope to see you again tomorrow in different rooms, having a great time learning and listening. Remember, there is a survey form in the chat box. If you can finally answer them, our organizers would appreciate it. And as usual, always use the hashtag, where's the hashtag? SEABCS 2022, Philippines, Manila, and PH. Maraming salamat po. Good night.